mouth here. This is the nose, with two eyes and a very long. She's covering the head with something. You see, two faces of young lady and old lady, but people can see many different things as you have seen. Some of you have seen just one face, others have seen two faces, others have seen even an elephant, but there is no elephant here. Okay, so the ideology is not objective. So there are some slides that will not take time, like different five densities you have in radiology and on chest radiograph. You know them very well. I'm not going to repeat, but the structures or object can be detected on chest X-ray if they are located next to structures of different densities. That's the reason why you can recognize the pulmonary vessels, recognize the heart shadow, you can recognize the mediastinum, the bones, because each structure is located next to another structure of different densities. Otherwise, I have told you, sorry, the reason why you cannot see the bronchi in the lungs, because the bronchi contains air and the alveoli contains air also. You see, because they have the same density, you cannot recognize them in the lungs. But blood vessels in the lungs, you can see them because they contain different densities. Okay, so that's what when two different structures are located next to each other, and you can organize them. That's what you call normal contrast in radiology.
Lecturer, I can't hear you.
Can you hear me, please?
Yes, now we are hearing.
Yes.
Someone had told me. Okay. The positioning and the views, you have seen them in the morning. I remember I told you that the posterior and the lateral, they are the ones we commonly use for chest radiography. And you know the reason why we do anteroposterior AP. You know the reason why you do the decubitus, lateral decubitus, rhodotic, and the obliques. If you have you know them very well, you have. Okay. That's one. The same. They're trying to explain why we use an AP for 2 ill patient. Okay, that one you know very well. You know the consequences of an AP film. You remember that the mediastinum.
Rector, ntabwo turi kukumva.
Ndi mu ishuri ndikoresha telefone yo kumpamagara nyuma ya 11:00. Ukambwira vuba vuba ko unahagaze deje, ubu wampagaritse deje, wahamagaritse abantu bose wa. Okay, turabivuganye, numva ko ari ibintu bisaba kubitekerezaho. Okay. Ndakenda guhamagara nyuma ya 11:00. Yego. Okay, can you hear me?
Again.
Yes.
So yeah, you remember the consequences of doing an AP X-ray. That one out. Other views, you know them, rhotic view, anti-rhotic view. You know those technical qualities you have to check, the 5 of them. You remember them, you know the importance of doing an inspiratory, deep inspiration on the exploratory phase films. Ibyo byose twabivuzeho cyane. You know them. These slides are now talking about that. Aha. So this is new for you. How can we interpret chest radiographs now? There are 3 steps. Ikibazo nyibaza muri exam zanyu. 3 steps. The first step
Okay.
is about patient identification. This is very important. If you don't go into details, you may think it is something very simple, but it's very important. Patient identification. The name, the age, the time of examination, you know, type of exam, patient number or something. Those are included in patient identification. You should please check them before you go in, you interpret, you analyze an X-ray. Number 2, you have to check the technical qualities. Please check them very well. Otherwise, it will mislead you. Number 3, it's about now image analysis. By now, image analysis, you have to remember the 6 steps you have just seen. You know, that's description of findings, analysis of findings, analysis. Try to, the most important comes first, the less important afterwards. Interpretation, now you correlate the findings with the clinical history and make the differentials. So those are 3 steps you should always remember and pass through before you make your conclusion. Okay? So I give very much value to these slides. Okay. So let us now start by identification. The identification contains the name and birth of date or the age of the patient, the type of X-ray, is it PA or lateral? This comes into the identification. Is it PA, is it lateral, is it AP? And when it was taken, the date of examination, because you remember in one day you can make different X-rays for one patient. You can do them in the morning, like 3 times, even 4 for some conditions, some pathologies. And even you have to check the gender, because remember, you can X-ray, chest X-ray for a female patient can be different from a male patient, considering the structures you have to see in the chest, like breast shadows can change the appearance of X-ray. You see, the date, you know, you can give a report of an X-ray that has been taken like 6 or 3 months ago. Maybe you report and say that this patient has TB while he has been under treatment and improved. You see, so for example, when you are describing an image, you start by saying this is a PA film, this is an AP film, this is a lateral film of chest taken on this date, of the name, the patient called this and this, 30 years old, male patient. You see, by this small sentence, you have included almost all the identification descriptors. Okay, so this is very important. Okay, for still identification, this is trying to show you what you have to check: the patient identity, not the image, date and time, not the image projection, posterior, anterior, lateral, anterior, posterior, and the image annotation should be checked. I mean, like this, those are the image annotations. Some of the centers, they put many things, others they put very few. Like here, they have said that the patient was in supine position. They have used the mobile machine or the X-ray because the patient was in a C-section room. It was taken at 25 past 11 a.m. The patient number, the date of examination, even in they say that this left side here. So all of this has been captured on the film. So you should check them very well before you start analyzing interpretation. Okay. This slide, you know it very well. The views, even how they are taken, you know them. I will not go into details because this is a PA, this is a lateral, this is a AP, this is a supine AP, this is AP in erect position, this is the lateral decubitors, and this is lordotic view, okay, AP lordotic view. So number two, after checking the identification of the patient and our patient in radiology is a film, remember, when you are talking about identification of the patient, it's not just the patient, it's a film. Because for radiologists, they just bring for me the film. So my patient is a film. Should check now on the film every single details of identification. Number two is about now technical quality. That one you know. I will not repeat because I talked about centering. That's number one. Centering was or collimation. I talked about symmetry or without no rotation. I talked about penetration. We know when it is adequate penetration or it is over penetration or under penetration and the effect we can have on the film. Yeah, those are explanation of penetration. When the vertebral bodies are too visible, it indicates an over-penetrated film, which results in missing low-density lesions. And when the vertebral bodies are not visible, it is an under-penetration of the lung, and the fields appear falsely white. You have seen even the images. And deep aspiration, you know that it is in deep aspiration when you can count at least 9 posterior ribs or 6 anterior ribs above the diaphragm. That one you know. This mnemonic called RIP, rest in peace. R is for penetration. R for deep inspiration, P penetration, and hello. For rotation, I mean R
For rotation.
I for inspiration. You see where it is, and P for penetration. This is if you can check even these three are enough to say that this X-ray is interpretable. Okay. So who can tell me the technical qualities of this X-ray? Can you tell me? One of you can tell me the technical qualities. Is it good to interpret? Is it bad?
Lecturer, there is over penetration because I can see a vertebral body on the side, on the shadow of the heart. You can see them very well on where the your console is located.
ntabwo turi kumva lecture.
I had lost my network, sorry. Hello?
Hello.
Hello.
Can
Hello.
someone, have you tried to answer my question? Who can try?
Lecturer, I have said that I think there is an over penetration because
Listen, hello. Only one person should open the microphone. Switch on the microphone, otherwise it is noisy.
I have said that there
Still,
is
tell your colleague now to switch off the mic. Only you.
yeah, they have done.
Not yet. There are some people who are making some disturbances.
Everybody switch your mic, please. I want to interpret this image. Lecturer, I
Okay,
can
try
go
it.
on.
Yes, please.
Let me try. Yeah, I'm saying that there is over penetration of X-ray because I can see vertebral body on the heart shadow. So that is what I have seen. But another clarity because I see there is symmetry, is somehow good. But something I have seen already is about this.
What you are Emmanuel?
Yes.
So, but there's some people using the UR medicine and surgery something. Please mute your mic. People using UR medicine and surgery class of 2026. I don't know, microphone. Please. Okay, so Emmanuel, can you go ahead, please?
Yeah. Yeah. There is symmetry. The symmetry because if I see the end of this clavicle, at medial end,
Emmanuel,
distance.
listen, I don't know what you are doing because there are some people who are I imagine. How can you talk? Not you. There are some people who have refused to switch off the mic. If it is on your computer, you're using it with others, tell them not to talk then. Otherwise, go ahead, please.
Yes, oh, please mute. Yeah, I have seen that. First of all, there is an over penetration because I can see well vertebral body on heart shadow, and I see that there is a high vascular marking, yeah, more than normal on the right side, and even it's not only on the lower side, but even the above I can see vascular marking, which is high, but this X-ray has somehow good clarity because I can count the ribs, and there is symmetry because I see that from the medial end of both clavicle on left side and right side to the spinous process distance is equal, and I can see that there is a costophrenic angular sharp. That is what I have seen on this image.
Okay. So can you interpret this or you can repeat it? Can you decide to repeat it or it is interpretable?
Yes, it is interpreted.
While it is over penetrated, you said it is over penetrated.
No, it is not over penetrated. There is good penetration. As you can see, vertebral body which are not clearly seen. You can see them but not clearly. They at the region of the heart means that there is good penetration.
So maybe I can. I wanted to see from this image that you either you have understood what you said or not. But for the penetration, the reason for checking the technical qualities of an X-ray, it's for to tell yourself, is it, can I analyze this image or not? That's the reason. You, out of 100 images, very few will be 100% good in terms of good quality, 5 qualities you have seen. But even if you see 1 or 2 of the qualities are not good, that good as you wanted, doesn't mean that you cannot, you are not able to interpret. Like for the penetration, this is slightly over penetrated, slightly, because I can see the vertebral bodies. It looks like this, they have sent a lot of KVP, because I can see the vertebral bodies, even the intervertebral disc space is very well through the heart shadow. But even if it is like that, it is slightly, that it didn't affect the rest of the chest X-ray, because the lungs are clear, the vessels are clear. Even if you say the vessels are prominent, I don't see where they are prominent. Normally, this is a normal appearance of pulmonary vessels. The rest, the collimation is good. I can see they didn't cut any important part of the chest from up, down, and laterally. Even costophrenic angle in, there is no rotation, there is deep inspiration. It is a PA chest radiograph. It is interpretable. I can still go on and interpret. So even if I wanted just to see if you can see very well the technical qualities of film. This film is slightly over penetrated, because you see the spine almost very well. Everything you can see it in details. So slightly over penetrated, but it didn't affect much my image. Okay. So there are different methods you can read in books for reading chest radiograph. I'm going to go place to one. I want you to know even this one, but at the end, what we'll be using in practical, I will give you another one very simple, but let me go into details about this one. This one is, you use now an alphabetic way, like A, B, C, D, E, F, H, A, you see, A, F, G, H. Like for A, you check the airway, the trachea, the main bronchi. For B, you check the bones, each bones on chest radiograph. For C, you check the cardiac shadow, the configuration, the size, you see. For D, you check the diaphragm. E and F, it's equal lung fields. Check the lung fields. Are they equal? Is there any abnormality in the lung fields? And you use gastric bubble. So gastric bubble, it doesn't mean anything important. H, it's for checking the hilum. Remember the location of the hilum. Left one is a bit higher than the right one. You check the shape of the hilum. And the hilum, let's check the size. Is they widen? Is it or not? So let us go into those details now. Which you are looking at, you have to check 4 S's. Those four S's are the site meaning the location, the size, the shape, and the shadow meaning the opacity. Please remember to check if you are looking at the heart, check the site of the heart, check the size, check the shape, and check if there is any opacity, abnormal opacity or not. If you are looking at, I don't know, lungs, check the site, size, shape, and shadow and opacity. If you are looking at the trachea, please do the same, okay? So for each structure, this is used in radiology. That's what we use even as today. If I'm looking at any structure in imaging, even for MRI, for CT scan, these four S's, I have to check them, okay? So for like the trachea, as you remember, it is for airway. I check the trachea and its branches. Is it part or narrowed, indicating stenosis or edema? Is it central? That's what you have to see. Is it central, the trachea? Is it central or deviated to one side? And you have to remember that in children, it should be straight, but in adult, it can deviate to the right side due to the aortic arch. I will show you. Aortic arch has tendency to push it to the right side for adult, but for children, it's straight. When it is not straight, you have to look for the cause. Like this is the trachea. Can you see on the image here? The trachea, the size is good. It is central. But when you come down, it is slightly deviated to the right side because of this aortic arch. Okay, and you have to check the main bronchi. The right one is more vertical, the left one is more horizontal, and this can have clinical implications. You remember, okay? And you have to check the carina. You remember the carina angle should you have to get in your mind that the angle how it is. If it is widened, you have to think of something like a cardiomegaly, especially the left atrial enlargement. Okay. So remember, it should be between 60 and 70 degrees. Yeah, that is for the trachea. Okay. For B, it is bone. Bone, I don't talk much, but you have to check each bone one by one. You don't have to look at them as one entity. No, check one by one. Take right clavicle, check it very well in totality. Go to the left one, check the ribs one side, check one rib by one rib, posterior aspect and the anterior aspect. Go to the left side, check the spine. You see vertebral bodies, check the humeri, and if they are in, check the shoulder joint. And by checking them, we are looking for any fracture, for any lytic lesion. When I say lytic lesion, do you understand what it means? By the way,
No.
what is the lytic lesion? Answer. Someone said yes. You like that word? Yes, but tell me what is the lytic lesion? How do you think? How does it look like? A lytic lesion.
It will look black because maybe there is destroying of the bones.
Yeah, it is dark. It's even written there, but even the lung, lucency comes from this lytic. Lucence, that's dark area. Like pneumothorax is recent area without any vessel. That's pneumothorax. So it is opposite to opacity, opaque. Lytic, opaque. They are opposites. And check if there is any bony deformity from anatomy, like in lachitic locally. I check if there's any extra bone, like cervical ribs. It exists and can cause even pain. Check if there is any missing bones.
So question,
Yes.
So what is it? We didn't understand well.
See, he has answered very well. Elytic lesion, it is when you like for the bone, we are in the bone. And you see that there is area that's darker than normal. You know, it has made the bone to be some focal darkness. It's like opposite to opaque than normal in the bone. You see, it can be caused by different diseases. Okay, different diseases. Yeah. Okay, but the appearance is darker than normal. Okay.
Yes.
Okay, at that area, so it means can be a cyst, bone cyst, can be abscess, can be anything. Okay.
Okay.
Mm. Okay, so see, it's about the heart, cardiac. On cardiac, still use that 4 S's I have told you. Site, is it located on the right or left? Is it dextrocardia? The size, you have to how to measure the cardiothoracic ratio. I told you about it. We will see on the image here today. Check the shape. Is the apex of the heart pointing to the left or to the right side? Normally it should point to the left side. The shadow, in any change in the density, any focal opacity within the cardiac shadow. The border, is it clear? Is there any silhouette sign positive or not? You see? If there is unclear right border, suggests middle lobe consolidation. That's what I remember I told you about middle lobe consolidation, lingular lobe consolidation. Normally, the opacity that can make the margin of the heart on the right side to be not seen, not well outlined. It means that that opacity is the middle lobe, right middle lobe. When it is on the left side, the margin of the heart on the left is not clear due to any opacity. It means that opacity is in the lingular segment, not lingular lobe, lingular segment, because it is the lingular segment that is a part of the left upper lobe that's in contact with the heart. That one I explained very well. Okay, like now, this is now how I wanted just to show how you measure the cardiothoracic ratio. Remember, the heart is in an oblique configuration. You know, the first point on the left is at this level, but on the right side, the first point is that level. And you cannot make a diameter in oblique way. When you are measuring this, the diameter should be horizontal. And you cannot measure the diameter at this level because it will be underestimated, undermeasured. You cannot make it here because it will be undermeasured. That's the reason why they have demonstrated as if you make a midline and you measure the diameter that up at this level, and you come at that level, you do addition. And now after that, you remember I told you for the diameter of the thoracic diameter, you measure it at the level of diaphragm, and you come from in to in, you remember. But in practice, you cannot make line for each X-ray. What you do, you put a ruler here at this level, and you bring it down at this level, because at this level it is where the left side, the farthest point is at this level, but on the right side, the ruler number zero will start not in contact with the margin. It will be a bit far perpendicular to where the farthest point is on the right side. Do you understand? You put the ruler here and you bring it down. Well, because now we use, that is for the film, but because we are now digital, nowadays, it is easier even to measure this. It is easier to measure the diameter of the heart because you are using computer. So you don't have to struggle with this. On digital, on the machine, it is easier to make a line here and a layer, and you to measure the diameter. Okay. And I told you, remember, You may the diameter of the heart divided by the thoracic diameter for a normal in a PA chest radiograph, in a PA, not the AP. For adult people, it should not go beyond 0.5. Okay, that's a ratio. When it is more than, remember, 0.5 is about half. The heart should not be more than a half. The size of the heart should not be more than a half of the chest diameter. For children, young children, it can go up to 0.6. Okay. Because the children, they don't do deep inspiration, they are not able to do deep inspiration, number one. Number two, most of the cases for them, it's the nappy view. That's the reason why the young children who cannot make a deep inspiration and to whom they have done a nappy chest X-ray, it is acceptable to measure the cardiothoracic ratio for them. And the normal one can go up to 0.6. Okay. Is it clear here? Yes, I hope. Okay. Remember, I told you about the silhouette sign. Remember, silhouette sign, like this image on your left, we can see an opacity at the base of the lung, an opacity at the base of the lung, and that opacity is silhouetting the right border of the heart, but it's not silhouetting the diaphragm. Can you see? By seeing this, and it has some air bronchograms, meaning it's a collection. And by seeing this, immediately you know that this opacity is located in the right middle lobe, because the opacity in the right middle lobe is the one that is silhouetting the cardiac border on the right side. Okay? But it is not extending to the lower lobe because the hemidiaphragm is clear. It's very well outlined. If the opacity was extending to the lower lobe up to the base, which you should even have seen the straight sign positive to the hemidiaphragm also. Okay. This is another image on the left side where you have an opacity. It is alveolar opacity apparently, and it is silhouetting the heart on the left side. And but the hemidiaphragm is clear, very well outlined, and I'm very sure that this opacity was in a ringular segment, in the upper lobe ringular segment, because otherwise the opacity could not cause the silhouette sign to the heart. Very clear? I hope so.
Yes, sir.
So D, it is diaphragm. You look at the outline of the diaphragm, it should be very well outlined. It should be clear and smooth, the diaphragm, either on the left side or right side. And remember that the right hemidiaphragm should be higher, 2 to 3 centimeters than the left side. Normally, not every time, but normally, commonly it should be higher, 2 to 3 centimeters above compared to the left side. And you have to ask yourself if is there any costophrenic angle is well defined and with a very sharp angle. The whiteness immediate above the diaphragm to think about opacity in the lung, or if there is any pleural effusion or consolidation. The presence of fluid will produce a meniscus sign. Do you know what is a meniscus sign?
Yes, lecturer, no. No, I know.
Oh, you know?
Yeah.
Tell me what is a meniscus sign?
Meniscus sign is when there is pleural effusion in the costophrenic angle and it is not bright. Instead, it's like a concave from on the top of flora. pleural, no, on the top of pleural effusion.
This is a sign of pleural effusion, by the way. It's a sign of pleural
Yes.
effusion because you can see the same opacity without meniscal sign, and they don't call it pleural effusion. Pleural effusion, it has a meniscal sign, especially if the amount of fluid is much enough. You see a concave line, and the upper part of that concave line is from the lateral aspect. The upper side is the lateral aspect, and the lower side, the lower part is the medial aspect of that line. That's the meniscal sign, and there's a sign of another sign I have to remember. It's a sign of pleural effusion. We'll see some of the opacities that may be looking like pleural effusion or pleural base opacities, but they don't have meniscal sign. That time we don't call it pleural effusion. Okay, so that is also a very important sign in radiology, in an X-ray, in a chest radiograph. Okay, you have to check if there is, for the diaphragm, if there is air below, free air. I said air, but it's a free air below each hemidiaphragm, indicating bowel perforation, what you call pneumoperitoneum. If there is a free air below the diaphragm, it can be seen over a chest radiograph. Is there a diaphragm below the anterior end of sixth rib on the right side? If so, this indicates hyperinflation. Do you understand this? Hyperinflation of the lung, when you can see the whole rib, sixth rib, can be seen above the diaphragm completely on the right side. Okay?
What you mean?
Is it clear? I mean, when the whole rib of the sixth rib is completely above the right hemidiaphragm. Okay?
Yes, for sure.
The whole sixth rib is anterior rib is completely above the diaphragm, the right diaphragm. It may be a sign of lung hyperinflation. You remember on normal chest radiograph like this one, like now, the one number 1, 2, 3, 4, 5, 6, almost 6 is crossing the diaphragm. But when the sixth rib is completely above the diaphragm on the right side, it can be a sign of hyperinflation. That's what they say. Okay?
Excuse me.
Hmm.
In some literature, they don't say 60 they say 70 free.
Exactly. In my literature, in some literature, they say seven, the seventh one. But it is, even for the seventh one, it is not 100% true. That is hyperinflation. But even when the patient has done a deep inspiration, the sixth, even the seventh rib can be above the diaphragm. In that time, it is somehow hyperinflated lung, but it is not abnormal as because the patient has done deep, very deep inspiration. Deep inspiration. Why the lungs are very much expanded, and now even the sixth, the seventh are above the diaphragm completely. So you have, as the radiologist, what we do, we judge according to the clinical history of the patient. Okay?
Yes, it's clear.
Okay. So who can tell me number? Let me even call someone. By the way, I'm saying who can tell me? I have your names here. Let me check. Who is Bibgireyesu Olivier? Where is Bibgireyesu Olivier?
Yes, I'm listening.
Kwanza mwamba ya marisi yanyu kanzi ndebe ko muhari mwese. Listen, can you try to interpret this the left the X-ray, chest X-ray of the left, on left side, on our left. Try to tell me what you see. Look at it first. Technically, is it okay or what? That's the first thing you have to check. Tell me about technical issues. Technical issues.
But about technical issues, it is somehow okay because we are there is saying
Sorry?
about technical. I think it is okay because there is a symmetry when we look for the medial ends of clavicles and we compare
That's
also.
Can you see it very well? Yes, Olivier, don't cheat him. Don't cheat us. Like, okay, for you, I know you don't see it very well, but me, I can see there is rotation to the right side. Because the median of clavicle is here. Can you see my cursor?
Yes.
The median is here. The spinous processes are here. The right
Yeah.
on the left side is here. Is this different? This distance is the same as that one. There is slight rotation to the right side. That's one.
Yes.
Not be. Kya kabiri?
Uh, Another thing is about collimation.
It okay?
No, because there is no neck.
They have cut off. There is a risk of cutting off the apex. You should
Yes.
see part of the soft tissue of the neck. It's
Maybe
not coordination is not good or centering is not good, but otherwise the rest is okay. How about penetration?
about penetration, it's a good because
Yeah,
spinal
it is.
process is slightly thin.
That's good. Penetration is good. How about
Yes.
the inspiration?
Uh, about separation,
Deep inspiration.
it is not good because uh, we, I think I cannot really see about six anteriorly.
How can you see them without the lower limbs? You don't see them. How can you count them? Imagine.
I think the first two.
You should answer. You should answer that you are not able to count them.
Yes.
Why imagining it?
And
Ntukajye uvuga amakuru utahagazeho.
yes, lecture.
None se kuko mbeshyira mbese. Ushaka kuvuga ibihumbi. Ikindi, what else? Is there any angulation?
I think no.
No angulation. Okay, that's good. So let us go to interpretation now. Analysis.
About analysis, I see there is positive meniscal sign.
Don't say Manisa. A sign is given by. I'm not talking to you. I'm talking to the group. A sign is given by an opacity. First of all, you should describe the opacity at the base of the right lung. That is opacifying the costophrenic angle is opacified. That's silhouetting the hemidiaphragm on the right side. It's also silhouetting the cardiac margin on the right side. Okay, it's cardiac border, and it has a meniscal sign. Can you see this meniscal sign?
Yes.
The upper part of it is on the lateral aspect, and the lower part on medially. That is a sign. This is a meniscal sign, and it is a sign of pleural effusion. Like now here, don't call it pneumonia. If there was no meniscal sign, you should have called it pneumonia or consolidation. But because there is a meniscal sign, it's a very important sign. You know very well that this is pleural effusion. Okay? Is it okay?
Yes, it is okay.
So how about, is there any other opacity, any other abnormality here? on this image. Is there any other abnormality? Is there any other abnormality?
There is
Yes, younger no.
no gastric bubbles.
Gastric bubble is not abnormality. It is there, but it is not abnormality. Gastric bubble is when tumariye twebwe. Yeah, bihari cyangwa idahari.
The apex of the lung has some heterogeneous opacities.
Exactly, that's very good. There is some opacities here. It doesn't look like here. There is opacities here. And this is, I think this is pneumonia, by the way, because it's alveolar opacity air bronchograms. So I think this is a consolidation. It may even be the cause of this pro-effusion, I think. Because remember, if it is pneumonia, it's inflammation, it's infection, it can even cause reactive pro-effusion on the right side. Let us go to the left image, to the another image here. Another person, let me see. Rosine, are you here? Rosine, where is Rosine? Rosine ndashaka avuga kandi arahari. Ko atavuga se? Rosine vuga cyangwa ugende bigenze.
hari ba rozine benshi.
Oya, umwe muri bo atavuga ntihagire uvuga, hari icyo bitwaye. Niba ari benshi se barabura kuvuga. Where is Rosine? Abarizine benshi ariko ubwo. Muhayimana Lucy. Abo bari mbishyize mu mutwe ntabwo nzongera kumushaka no kuvuga umuntu. Abantu mbaza niba ari na benshi niba bagombye kuvuga ahubwo continue. Lucy Muhayimana Lucy. I have an impression that some very few people they talk. We talk when I am teaching. They very few they respond to my questions. Others they just keep quiet. I don't know if they follow or not. I'm going now to use the list because I should know who is responding, who is following. Ubu ndabizi bazaza nyuma, hari aho dukoresha ibizamini ugasanga aje nyuma ari kubeshya ngo dogita ngo none se urambwira nkamubaza none se urashaka iki. You didn't follow my lecture. You are not participating to my lecture. Uragira ngo ngire neza. Kandi nicyo bigaragaza nyine umuntu udasubiza nuvuga ngo nta nubwo ababyumva, umuntu uri aho w'indorerezi gusa. I can see, Lucy, continue. I can see that you are switching on your mic. Just talk. Muhaimana. So tell me about this image. This on the right side. What are you seeing technically? Is it okay? Is it bad? How is it?
It is okay.
Sorry?
It has good penetration.
It's good penetration. Ntabwo ari byo bivuga technically good. Just say, talk about everything in technical aspect of the film.
I have seen chrysophrenic arms.
Sorry?
Chrysophrenic arms.
Please talk. Vuga byose ntabwo mvuga jewe. Just talk say what you want to say. And when you finish, tell me that you have finished, and so that I can comment on your answer.
About semi-precision, it's good because the classical approach is good.
Sorry? Nta kintu numvise yewe vraiment. Vuga ibyo ugomba kuvuga ubwira urangize madamu tujye no ku bandi, otherwise uratesha umwanya munini. Ye ntabwo ndi umusivile nk'abandi benshi. Abantu biga ko mujye mubaserereza abantu biga i Huye batazi kuvuga vuba. They should be like kwara gisivile ari. They are civilians. Kandi iyo ndi kubigisha face to face, I can see the difference.
abasivile bihuye
Abasivile bihuye ntibazi gusubiza, ntibazi kuvuga, niba byabananiye ngo tugiye ku bandi.
Abasivile bihuye rwose.
abasivile bihuye
ariko ko tubarusha
Wenda yibonye ko mubarusha, abiga ko muba muri sharp, you talk.
biga ko tuba turi sharp cyane.
ntabyo baturushaho.
Barabarusha, nta muntu ubaga ko utinda gusubiza, ntibishoboka. Arasubiza byamunanira tukamubwira ariko byamunanira.
Sinjye wasubije cyane.
Wihuye baratuzi.
Ni wowe yasubije cyane.
Njyewe Emmanuel dusingiza Imana.
Bari gusubiza bakujyane gako rero.
bamujyane gako
ariko igako bafite sirake.
Sirake ni gako.
Ora nakihuye ihuye.
Sirake ubwo azabahagararira nta kibazo.
Siradusubiza.
Sirake, can you answer my, please, and try to interpret this image. Sirake.
Okay. Technically, it has good penetration because the spine is faintly visible. It has no rotations because from the spinous processes to the medial side of the clavicles, it's equidistant on each side. It has no angulation and the centralization is good.
Ntabwo mwumva ukuntu Sirake azi gusubiza neza. This is now, make sure you do radiology as a specialization.
Ni nkanjye neza.
That's very good, man. So let us try to interpret then. What are we seeing as an abnormality here?
There is air under diaphragm.
But listen, by the way, the reason why I'm putting in these images, I want you to know how to look at the image systematically. Don't just jump from diaphragm going up, coming back to the cosophrenic angles. No. You should start by follow that A, B, C, D. Otherwise you'll miss everything.
Yeah.
Follow it. Set airborne, airway bone, airway bones, the heart, cardiac, lung field, gastric bubble, though it is not important, and H is a hemidiaphragm, I mean.
Yeah, thank you. On the airways, I'm saying that there is no problem. About bones.
There is a problem on airway.
No, there is no problem.
Okay.
On the bone, as we have seen that we have to look if there is any fracture, if there is
any lesion of the bone.
Yeah, there is no I'm seeing no fracture. There is no lytic lesion. Even there is no bone deformity. I think I can go on C, which is cardiac.
Okay.
As I'm seeing, the heart looks normal. There is no cardiomegaly, if I'm seeing well.
Okay. Yeah, you are right. It is not going. It's not more than half of the chest wall, the chest diameter.
Yeah. Then, by continuing on D, which is a diaphragm, which I have started on before, there is an air under diaphragm.
Which diaphragm?
Especially the left one.
Where is
No, on the light there is an on the peritoneum.
Okay, but how do you never say there is air under the diaphragm? Because air is always under the diaphragm.
Yeah, I know.
There is air. You have to mention that free air.
Yeah,
it's very important.
Yeah. It's a free air, and there is a systematic term which I use to describe that condition, which is called pneumoperitoneum, I think.
Yeah, it is pneumoperitoneum.
Then about I think by now that's all.
Okay, so your conclusion?
My conclusion is this: this patient, we deal with these free airs.
Pneumoperitoneum. That's your conclusion.
Yeah.
So my question is this PA or AP?
It is a PA.
Why?
Because by seeing on the scapula, they are upward, and even on the clavicles, they are not horizontally as on the AP. And even the size of heart, there is no cardiomegaly.
It is not always there. In the AP, there is no always cardiomegaly, but listen, this is an AP.
An AP?
This is an AP. It is even written there. I wanted to see if...
That's PA, teacher.
It is even written up. It is written AP sitting.
Yes.
AP sitting.
AP.
I wanted to see if you read all the
details
before you talk.
That
was
abasivile bihuye ntibazi no gukopera.
Wowe umusivile bihuye?
Lex urumva umuntu wavuga ibintu bingana gutya ari umusivile.
It is from near me here.
Ntabwo ndi ariko ndi umusirikare w'icyaha.
Okay, let us go to next image. Okay, equal lung, remember it's equal lung field. Listen, very importantly, we remember that on chest radiograph you cannot see the fissures. Okay, so we are not, in other words, you are not able to divide the lungs into lobes on chest radiograph. It is very difficult. If you cannot see the fissures, you cannot divide the lung into lobes. So what we do, we have tried to, people, not me, they have now divided the lungs into 3 zones: upper zone, middle zone, and the lower zone. And they say the upper zone is from the apex to the second, to the inferior margin of the second course, to the second rib, anterior rib. Okay? And the middle lobe zone, not lobe, is between the second rib, anterior rib, to the fourth one. And the lower lobe zone is between the fourth up to they say the sixth because it's the one that touching the hemidiaphragm, but up to the lower margin of the lung. So that's how we divide now. When you are describing any lesion, any opacity, you can say the opacity is in the right middle zone, or left middle zone instead of talking about lobe. Because remember, on chest radiograph, because it's a 2D image, some lobes are superimposed, like the lower lobes are always superimposed with the middle lobe posteriorly. So that's the reason why we use in description, we use upper zone, middle zone, and the lower zone. Okay? So this one you have to remember very well. And again, after dividing the lungs into zones, 3 zones, now you look for equal radiolucency. You remember lungs are radiolucency until there is no opacity. Okay? Between the left and the right lung zones. So when you are looking at the lungs now, you compare the left and the right upper zone and you compare the recency, radiolucency. Is it okay? Is no any asymmetry? Okay, there is no any opacity somewhere, any nodule, small opacity, any asymmetry in the size. You see. After that, you go to the middle zone, left and right. You compare them very well, and you go to lower zones. Okay, and look for any discrete or generalized gray white shadow opacity. Okay, opacity, patchy, opacity, normally patchy. It's a term is what our descriptor. Patchy means something opacity that is irregular, that not sharp. It is irregular opacity. It's called patchy opacity. Okay, you should remember this term because we use it frequently. And again, the horizontal fissure on the right divides the upper and the middle lobes. From the hiram to the sixth lip of the axle line. But this is not important because it's very difficult. They said the horizontal fissure on the right because you remember I told you it is the one that can be sometimes, very rarely, but sometimes can be seen on chest radiograph. Okay. And you have to remember that this divides the upper and middle lobe on the right side when it is there. But generally, you can't see the fissures. When you cannot see them, you will use now zones. Okay, when you are looking at the lungs now, check the left and the right zone. Upper zone, you check very well and you compare middle zone and the lower zone. Okay? Okay, is it okay here?
Yes, it's okay.
Yes.
By the way, I have an image. I have the image here. Can you see? If you check very well, this is the first anterior rib, and this is the second one. Where the inferior margin of the second anterior rib now, it is where the margin, the limit of the upper zone. From the second one, because the second one is here. From the second one, the third and the fourth, it goes up to down here. That's the middle zone. And downwards now the lower zone. And now when you're looking at the lung, now you have to compare this upper zone, the right side, and the lower zone, you compare them, see if there is any difference, any asymmetry in size, any opacity. And the middle zone, you do the same. You compare this right and left, the same as left at the lower zone. Compare the left and right. Every structure you see in these zones, you have to check, compare the diaphragm, is it the same as there? Is it very well outlined? The heart margin, is it okay? Costophrenic angle, is it okay? You see, you compare each in details. And remember in the lungs, lung field, what you see, it's air and blood vessels. And remember, blood vessels should be very thin. They should be very, should have smooth wall and oblique orientation. Okay?
Lecture.
Yes, I can hear you.
Muri previous slide bavuze ko the lower zone lies between 4 and 6 coastal cartilage. Ariko aha ngaha kuri image ndabona bari no kugera hasi kuri diaphragm, so how?
Is it today in the morning? I told you, is it last time? I think yes, that is yesterday. I told you that the lung, posteriorly it goes far. The lung limit is not here. So I remember I told you, and I was even demonstrating. The lung field is not limited at this level. hari umuntu yabyumvise mbivuga
wabivuze mu gitondo
ntabwo yari ahari rero ubwo nyine impita mwumva nyine umuntu utari uhari
oya wabivuze ahubwo
posterior ahubwo iki kandi
ni uko wari utubwiye ati tubara anteriorly turi
ariko se
kubara
ntabwo uzi
zino
ko
zone
6 rib usigera he hano uragira ngo 6 rib ntabwo ishobora kuba ari iyi ngiyi this one if you count very well it can even this one ku buryo it goes up to the 6 rib anteriorly 6 rib I think is this one or even if it is this one it goes up to this level can you see so nta kintu na kimwe gipfuye kirimo gusa remember that posteriorly the lung fluid goes up down posterior to the diaphragm.
nabyumvise.
Okay. So, listen, this slide is also somehow important. You have also to look for, in the lungs, you have to look for the vascular markings now. You can diagnose pulmonary hypertension. There is what you call pruning sign. Pruning sign like this. Pruning sign, it's when from the hilum, the vessels are prominent in pulmonary hypertension, especially in pulmonary arterial hypertension. At the hilum, the vessels are prominent, they are marked prominent, but immediately they are like cut off on both sides. They are like cut off peripherally. It's too recent and there is no blood vessel. That is what you call pruning sign, and it is seen in pulmonary arterial hypertension. I don't know if you have an image. Pruning sign. It is a sign that's known, and that's seen in a pulmonary arterial hypertension. Okay? Is it okay? Okay. That's for vascular, but vascular markings, normally another information I have to give you, it's like 1/3 peripherally. Normally you cannot see, in normal circumstances, you cannot see the blood vessels in the lungs. 1/3 peripheral, 1/3 peripherally of the lung. You cannot see, you are not supposed to see the blood vessels. And again, remember when the patient was in erect position, standing up, the vessels are prominent downwards and upwards. They are not. They are not prominent. They are less prominent. Okay. And in the lungs, more specifically, you have to look for air bronchogram sign. You remember, and what it is. You remember the sign, air bronchogram sign. It's a sign of consolidation or fluid collection in the lung. And there is something what we call bat's wing distribution of the opacity. Bat's wing, it is opacities that are symmetrical in the lung, both lungs symmetrical. It is, this sign is paracardiac opacities, that is alveolar opacity, that are symmetrical, and is in most of the cases sign of pulmonary edema. Okay, pulmonary edema in heart failure. But also there is what we call reversed bat's wing, where now the opacity are peripheral, not medially. They are not paracardiac, then peripheral, but medial there is no opacity. That's called the reversed bat wing. That is normally seen in fat embolism, in case of trauma, like femoral fracture or something. Fat embolism. When you see a reversed bat wing, distribution of opacities or alveolar opacification, think of fat embolism in case of trauma. But bat wing opacities, this is commonly seen in pulmonary edema. Okay? Is it clear?
Yes, clear.
Like this one, by the way, I have images. Like this one, this is the heart with silhouette sign. Silhouette sign doesn't mean completely opacified, no? This silhouette sign, because you cannot very well outline the margin of the heart, the silhouette sign with patchy meaning irregular, alveolar opacities that are symmetrical. You can see. It's like what your number, you see? They're symmetrical and pericardiac and silhouetting the heart margins. This is a case of batwing appearance of opacities, and most commonly it is seen in pulmonary edema caused by anything, either heart failure or any other cause of pulmonary edema. But on this image, second one, you can see asymmetrical opacities that are also alveolar opacities, but they are the periphery. Centrally or medially, there is no opacity. You can see the margin of the heart are very well outlined. This is now reverse batwing appearance of the opacities, and it is seen commonly in fat embolism. Okay? Clear?
Clear.
Okay. Waji. So, still in the lung, you can see some different other not alveolar opacities like what you have seen. You can see what you call Kelly lines. Kelly lines, we have 3 types of Kelly lines, even more. By the way, some are described as more than this. Kelly A, B, and C. But you can even have Kelly D. Kelly A, they are normally, the Kelly lines are the fine lines running through the lungs, representing thickened connective tissue. Remember, the lungs, the anatomy of the lungs. Do you know what you call a secondary pulmonary lobule? Write down and read it for yourself. Write down and this and read it in the evening. Secondary pulmonary lobule as anatomy of the lungs. It's microanatomy of the lungs. Secondary pulmonary lobule. Can be seen only on CT scan, but it has some very significant clinical complication. And the lungs normally are composed of 2 important parts. The first one is alveoli. Those are pocket of air. But between one alveoli to another one, there is what we call connective tissue or interstitium. Connective tissue or interstitium. And that connective tissue, it's where passes now blood vessels, arteries and veins, lymphatic vessels, and even bronchi. All those 4 things, they pass through the connective tissue between the alveoli, you see? So now, Kelly lines now, they are fine lines running through the lungs, representing thickened connective tissue, septi. Septi, that is the connective tissue that is separating one alveoli to another one, seen in interstitial pulmonary edema. Not only in pulmonary edema, it can be caused by anything, any correction in this interstitium. The shape will come as linear, it's linear opacity. It's no longer now alveolar opacity where it is patchy. By the way, linear opacity and patchy opacity are somehow opposite. So we can have what you call Kelly line A, Kelly A line, that lines that are found in upper lobes only. We can have Kelly B lines that are short and the horizontal line in the lower lobes peripherally, and the Kelly C line that are diffusely distributed in the lungs. Okay, that's how we differentiate those lines. Kelly A lines, Kelly B lines, and the Kelly C lines. And these Kelly lines may be associated with cardiac enlargement, and the pleural effusion in this case will now be caused by, it will be sign of pulmonary interstitial edema. So the first very early signs of pulmonary edema. Okay, interstitial edema, you remember that pulmonary edema can be at early stage, it's still at the level of interstitium. When I say interstitium, it's a connective tissue. Okay, those are the lines. Look here. Those are Kelly lines. Upwards, the Kelly A lines that can you see this? If you remember very well the normal lung appearance, but here we can see some lines like these ones. They are not vessels. Even the orientation is not for vessels. Peripherally, You know, remember that 1/3 peripheral should not be the blood vessels. But even if at the center, can see different lines oriented at different directions. Those are curly lines. A upwards, B at the base peripherally, and C distributed everywhere in the lung. This is magnified now. Which curls are these ones? Who can answer me?
B.
B.
RB.
These are curvy lines because they are peripheral located at the base of the lung. Okay? Can you see them? They are very clearly seen. But they are clearly seen because it is magnified. Normally, you should have a second eye, a third eye to see this on normal chest radiograph without magnification. All right. Any question?
Si kuyibona ko bizagaragara.
No, Uzaiwan, if you are used to normal chest radiograph, if there is any line that's abnormal, immediately you see them. You see that there is something abnormal. There's some linear opacity that are abnormal because the vessels are normally smooth, oriented, obliquely oriented, from center to periphery, obliquely oriented, smooth. In peripheral, they are not seen unless there is hypertension, venous hypertension.
Yes.
And in pulmonary venous hypertension, remember we see what we call cephalization. Cephalization is when the upper lobes vessels are prominent than the lower lobes, or they are the same level prominent. That is cephalization. Cephalization. Maybe we'll see the image. Cephalization is when the upper lobes vessels are prominent, become prominent because of pulmonary venous hypertension. Okay. So gastric fundus, I don't know the reason why they mentioned this. Maybe it is the reason not to jump one alphabetic, because normally it is not a sign of anything. Gastric fundus, a normal anatomy, it's normal. It should be there if someone is standing up. But they say we look for it just to see if there is any diaphragmatic hernia, especially in children. Okay. Maybe its absence may in someone who is standing up, and you miss the gastric bubble, air bubble. You can think of maybe there was diaphragmatic hernia or displacement of the stomach by something else. Okay, and the diaphragmatic hernia, remember, it can be either on the right side or left side. Do you know the differences? Remember to write down that you will read the second pulmonary lobar anatomy. Have you written that?
We have seen it.
Mwabibonye, mwari kuri internet, ntabwo mwamurikiraga. Just
Yes.
read it and understand what it means. For the next our next session, I know ntabwo ndi burangize ndabizi kurangiza iby'uyu munsi, because there is abdominal imaging tutari burebe, and I wanted even to share some images, chest and abdominal x-rays, so that I make sure you are able now to interpret the common diseases. So we need another one whole day from morning to evening. Okay. So diaphragmatic hernia, also read about diaphragmatic hernia, there are different types, and even the names. You tell me the names tomorrow. So for the hilum and the mediastinum, look at the hilum. And you remember the hilum consists of main bronchus and the pulmonary arteries. Normally, you know this confluence of this main bronchus and pulmonary arteries near the mediastinum. The left one should be a bit higher than the right one by 1.5 centimeters. And you have to compare the convex. Convex here, they mean convex medially, but is concave laterally normally. The hilum, normal hilum, should be concave laterally on both sides, but convex medially. That's how they said compare the convex shape and density of both sides. When that convexity or concavity is lost, think of anything like a mass, lymph node, or any opacity. I will show you on the image. And you have also to check for paratracheal lines that are thin lines of the right and the left tracheal margins, which are thickened and lymphadenopathy. Like this case, this is trachea. Now, paratracheal line is this one, the left one, and the right one is the right one. You see that on the image. And remember this. Remember this is aortic arch. Remember that azygous vein, it can be seen on X-ray. Right main bronchus and left main bronchus. Remember the descending aorta, continuous with the aortic arch here. Remember the left ventricle here. Remember the right atrium there. You remember diaphragm, continuous diaphragm. When you see the sign called continuous diaphragm, there is a sign in the letters called continuous. Normally, the diaphragm is not seen continuously. When you see it continuously, think of pneumoperitoneum, the sign of pneumoperitoneum. Utwo tuntu njye navuga sinzi ko mutwandika muzabyibuka ko mutamfasha amajwi. And they are the signs you always use in your life. Continuous diaphragm, it's a sign of pneumoperitoneum. When you see you can outline the diaphragm continuously from right to left side, the sign of pneumoperitoneum. Okay, so this diagram is the key landmark of chest X-ray. You know them already. Right hilum, left hilum. This is left hilum upwards, and the right one is a bit lower. Superior vena cava, you know where it is. You're supposed to be. If it is enlarged or dilated, you can think about it due to location of that opacity. Okay. So here, what photonashizo kenshi mwayimenye deja. What I can tell you, it's about like hilum. Can you see this concavity? It's concave laterally. Even this one is concave laterally. When you lose this shape, think of anything abnormal. You should always, when you are looking at hilum, check this concavity. Check this concavity. And check here, see how the blood vessels, pulmonary vessels are smooth, obliquely oriented, obliquely oriented, but peripherally you can't see them. One side of peripheral, you cannot see the vessels. Look, you don't see them. Okay? Is it okay? If you see, check how the diaphragm is not continuous. When you reach the heart, you can't see it. But when you are able now to look at it continuously, think that there is free air in the peritoneum cavity. What else? What else here I wanted to tell you? Paratracheal line. Can you see here? This is paratracheal line on the right side and paratracheal line on the left side. When it is thickened, now think of mediastinal lymphadenopathy, mediastinal mass or something. What is this anatomically? What is this? These structures, this one? Who can answer the question?
Transverse process.
Check very well on your computer. I am talking about this. This small one. Remember, these are spinous processes. But how about this laterally? This. You can continue seeing them up to downwards. This.
Transverse processes.
Transfer processes in nini cyane. These are pedicles. Have you ever heard about pedicles? Pedicles.
Yes, sir. Yes, sir.
Who can tell me what's this structure? What's this structure?
Diaphragm.
Sorry? Sorry?
Diaphragm.
Diaphragm is this one. How are you? Diaphragm, this is diaphragm. Diaphragm on the left side. But what's this? Because in radiology, everything is you should you should interpret everything you see. You should know what it is. Don't see something in the image like this one and you overlook it and just talk about something that is maybe it is easier for you to talk about. Anything you see in the image, you should give it interpretation. You should interpret, should analyze it and know what it is. That's the reason why I'm asking, what is this? You are not able to answer the question. And this image, it has been there for long.
Is esophagus.
Esophagus, normally the pathway of the esophagus, this one post anterior to the trachea and it comes like this. It doesn't come that way. It comes here. It's near the mediastinum. Fundus. What do you mean by fundus? This is the fundus. You know, it is in like now the fundus, the fundal wall is in contact with the diaphragm here. Because it's filled with air. It's in contact. And that is the question. It is a gastric, how do you call it? Gastric folds, gastric fold.
Ntabwo twari kubimenya.
Well, no, but impamvu ntabwo njya mubimenye nagira ngo gusa mwumve ko you should read each structure you see. Any abnormal structure you look at, please don't overlook it.
Lecture diaphragm ni iyihe?
Diaphragm ni iyi line. Don't say when diaphragm ni kisi membrane. It's a membrane.
Yes.
None se kubaza ngo ni iyihe? This is a diaphragm.
Kumva gari kumanukira hano hepfo gato.
That's the diaphragm.
Imano kwijya ntabwo uzi gutandukanya abdominal organs and chest. Ajya kumanukije. Maguru
Munsi.
Kera umenya uzi rero, let me tell you something. None se ntabwo mwakoze dissection anatomy?
Ko twabyumvishe mu matangazo ra.
Ntabwo ashobora mwakoze dissection.
Nta dissection twakoze. Yakozwe n'abantu nka bangahera bari batanu batandatu.
Ako mufite na machine ira machine yita machine automate or something. Nimuyifite? Ira machine ya anatomy ushobora kujya imeze nka electronic dissection. Anatomage, none se kuki mutayikoresha kugira ngo mwumve neza what is this? Like the diaphragm should understand how it is for you to understand how. I told you many times that the part of the lower part of the lung goes deeper posteriorly. So the part you see there, it is lung. The recent one is the lung posteriorly.
Yes.
The reason why you don't see it here, it's because there is a solid organ, the liver. Otherwise, you should have seen it the same, like you see it here. If there is any reason here, you can even have a pneumonia here, located at this level, and you are able to diagnose it because this is lung, you can see. Posteriorly, costophrenic angle goes deeper than anteriorly. That's how your anatomy is. It's the same as you. It's not for this special person. Posteriorly, the lung goes deeper. Okay.
Lecturer, about those gastric air bubbles are normal because I see it's a big one.
Yeah, it's but it's not the first time we see it. It's the second time, and I explained the reason. Last time, rega, jewe ndi kuvuga aba abantu baza bagasiba bagafunga bakigendera ntakurikire. Ndabwiza ukuri, if I give a message, I suppose that one of you have followed it and have understood it. Now I'm going to kubaza.
Yeah.
If you have any question, umuntu agasubiza ngo no. That's good. It's like now it is the standard of air. Kubera wenda ibintu yariye cyangwa yanyoye ntabwo urarya ibintu cyangwa ikintu kumva inda yabyimbye. Yabirye murira hirya aho ngaho yapfa ngaho. Bigatera gazi nyinshi mu mara no muri stomach. Akaba over distension of the stomach, like this one, gas ya distension of the stomach. And this naibwiye ko ntabona se ko byanateye there's some effect on the chest radiograph. Like the hemidiaphragm on the left side was not supposed to be at the same level as the one on the right side, but now they are almost at the same level, meaning is distension of the stomach, gas ya distension, pushing upwards the hemidiaphragm. This can even cause some pain, chest pain. Nibushize narabivuze ariko di abakurikira buri gihe narabivuze.
Narabivuze rwose ariko nyamya byibagiwe.
Can I continue?
Yes, you can.
Ese abantu bavuga ko abakobwa batajya bavuga nta barimo muri ni bake? Hari umukobwa umwe ujya uvuga sindamenya izina rye, umwe gusa n'ujya usubiza abandi ntibajya bavuga. Yo.
Abiturije.
Remember that I told you how to describe an image? Like this chest X-ray, even if there was... What's wrong with this X-ray, by the way? Who can tell me the something wrong from this?
About the correlation,
very bad.
It is very bad.
Very, very bad.
Yeah.
What else? What else? What else? Tell me.
And it is over penetration.
Attention, penetration. Listen, in radiology we have always convincing facts. When you say over penetration, it looks like you have forgotten the criteria, the definition of over penetration. By definition, what is over penetration of the film? What is over penetrated film? By definition. Tell me.
I think
we say there is a penetration if there is clear, if the vertebral bodies are clearly seen and within the lungs it is too.
When I say how is it here? How is the spine?
It is a faintly seen.
Faintly seen.
Yeah.
It's faintly seen.
Not clearly seen.
Yeah. If you by definition, sorry, I was busy. By definition, this is not over penetration. It is normal penetration. It's adequate penetration.
I think he wants to say about the lungs that it is hypercalamic.
Why is the lungs too dark?
And narabisobanuye ariko mana yanjye we narabisobanuye koko nakuzugunda bagira gute? Umva rero ye groupe yanyu yaranyebeye rwose. Groupe yanyu murirarira murabeshya kandi kwirarira ni bibi. Mwe muranyumva neza?
Reka no.
It's okay. It's okay. We will continue. It's okay.
lecture mubivuga turi kubyumva neza ariko iyo hashize nyine igihe tugenda tubyibagirwa aba ari byinshi kandi n'ubwa mbere twize nyine medical imaging.
Iyo twavuganye uyu munsi mo murambeshya none se ntabwo nigeze babwira ibintu bya exposure, ntabwira n'impamvu yabyo.
Mwabitubwiye exposure.
Penetration imeze neza kandi lungs zikaba ziri dark gutya, kivuga ngo ntabwo over penetration imeze neza ariko lungs are
ariko means that the amount of X-ray are high and KVP is low.
The number.
Yeah.
Even by MIS, the number, but
yes.
But the KVP is normal.
Yes.
This is called overexposure. This is an overexposed X-ray, okay?
Yes.
But with good penetration. Giye gukosora wagira ukambwira ngo yagabanye MIS, yagabanyeho gatoya. Ntabwo wambwira ngabanye kuri KVP. Ariko naho muragerageza mutarayibona mukabyumva amagambo gusa ntabwo byoroshye.
Turagerageza.
Okay, so if you're trying to kuvuga it's not that one. I wanted to tell you how we can describe an image. Like now they said this is the posterior anterior chest X-ray of X, born on this date, taken on 25th. It's well centered, but that is the centering with no rotation. There is good penetration as indicated by the visibility of the vertebral bodies through the heart shadow. The trachea is patent. Now atangiye avuye kuri technical. Wetse kanga batavuze byose nzabihindura. Ntabwo ugeze bavugamo ibintu bya collimation bayivuzemo. First barabeshye nzabihindura ejo bundi. Bavuze well centered. No way. This is not well centered. There was no rotation. I agree with them. But they said good penetration, but they should have added that it is exposed.
Yes.
And again, they should have technically they should have gone find say deep inspiration and those 5 things. They should describe them at this level. But now they have started talking about the interpretation. The trachea is patent. I can see it on number C and deviated to the right side. Is it deviated? Kana byihutirwa cyane. Yego. Turazikora neza kwigisha. Mukanya saa 11. Okay. Nyuma saa 11 mpamagara nta kibazo. Okay. Sorry. Can you follow me? Hello.
Yes, sir.
Okay. So you should now describe the description. The trachea is patent in the right side, which can be normal, especially for adult. There are no bone abnormality noted. When B yahereye kuri trachea A, the heart is C. The heart is normal in size, shape, and location, with the apex in the left fifth intercostal space, the mid-clavicular line. The cardiac borders are clear and well defined. The chest is not hyperinflated. Remember what it means. And the cosophrenic angles are sharp. Both lungs field are equal. Lung field are equal in the radiolucence with normal vascular markings. Narabeshya ariko ntazo turi kubona hano bashabana n'ababeshyi bose. Tumukajye mupfa gusoma ibyo mubonye ngo mubishire. Nk'ibinyago nigeze mbisoma ngo ndebe ko bimeze gutya. The paratracheal line are not frequent. Yeah, in so great internet ntabwo yose ari ukuri. Hano harimo ibinyoma byinshi we. The brachial lines are not thickened. Okay, maybe I'm going to sour. The mediastinum, the outline of the right for the azygous vein, the right hilum and right atrium of the left are clear and well defined, maybe. Okay, so pretty much just ask.
Question: how can you suggest that trachea is deviated to right or left?
You see, follow it. It should be central normally. They are talking about maybe when it comes. Is it? It looks like it is deviated a bit to the right. It is just push the bit to the right side. Normally it is that happens downwards here, where you cannot see it very well. Because it's pushed by the aortic arch, normally.
Okay.
Jesse.
Question.
What I wanted to tell you here. Hello.
Hello.
What I wanted to show you here, it's the for you to know how we describe an image. How do you explain? How do you describe it? Okay. The way you're going to tell is by starting by the identification. We go to description, and we end up by here. Maybe they didn't end up by conclusion or analysis and interpretation ntabyo bashyizemo hano wabibonye ko tutashyizemo cyangwa ntabyo mwabonye
twabishatse turabibona.
Do you remember analysis and interpretation, what it means in radiology, in the 6 steps I told you? Who can tell me what's analysis and interpretation? You are mubyibuka.
Yes, thank you.
Huh?
In analysis, you have to see the important things, and you try to correlate it with the findings in clinical history during interpretation.
Yes, exactly. So here in this report description, they didn't talk about analysis and interpretation. For interpretation, you have to mention even the conclusion and differentials. Okay. So this is another example of another example of description of an image. Check the image first of all. Unfortunately, I put the description. I should have asked you what are you seeing there on the image. Try to look at it. The image. It's a child. Can you see that's a child? Hello. Can you see that it was a child? So what are you seeing? What are you seeing? Hello.
I can see the heart.
You can see the very good one. You can see the heart?
Yes.
Wait, you can't see the heart really? It is thin. In totality, it is thin. Yeah, everything. There's some. Have you ever seen some structures like this in the chest? Huh? So you remember that in description you start by in analysis. You start by the more prominent findings, and you end up by less prominent. That the main prominent here is there are two. The first one is this structure that's not normal in the chest. Have you ever seen something like this in the chest? You should have started by talking about this now. And this has even has pushed the heart. This is the heart on the right side. The trachea and the heart, the mediastinum itself, the whole mediastinum is pushed to the right side. Okay. Is it okay?
Okay.
Hello. Hello. Hello.
Hello.
Hi.
Are you still there? What have you seen? So I was I was going to myself because I was talking to someone. But this is now. What does this look like? It's even written there. I have read. What does it look like? Huh? Nekwe. Iraboneka nk'iki. Don't you see that looks like intestines? It's like they look like intestines in the chest, and they are even the intestines in the chest. For a kid like this one, those are intestines, and again, we don't see very well the outline of the hemidiaphragm on the left side. Mutonya kuderanje muryame, kuki mutaryama? Yavuze saba iki? Urumva? They can there is the outline of the left hemidiaphragm it's not well, it's not seen, meaning the hemidiaphragm is sorted. There is a mediastinal shift to the right side. This is now hernia, the diaphragmatic hernia. It is even written here, the diaphragmatic hernia. But the way I say this is an AP chest radiograph, an AP now chest X-ray of this one taken the neonate intensive care unit on the day he was born, 14 something. This is an cemetery X-ray given that that's I wanted to show you how they describe it, and at the end they say the diagnosis of diaphragmatic hernia can still be made despite the substandard X-ray. So when you are doing interpretation, we can even interpret on some abnormal technical qualities. We say even if the X-ray is not of good quality, but you can think of this, you know. Ntabwo tujya tubeshya muri radiology ngo tubeshye nk'aho umuntu wambeshyaga atabibonye. Tuvugisha ukuri kose uko kwakabaye. Hello. Twagiye?
Hello.
So this is another one. But sinjya kubyinjiramo cyane muzabyisomera mwenyine. But what you say, there is over the there, and there is some cystic areas there. That would what you call in radiology nematocele. What is the cystic formation in the lung, and even the mediastinum is shifted to the left side. But this, I think, this blackness is due to technical qualities. I think there is also there is an compensatory hyperinflation of the right lung, because the right lung is compressed here with nematocele. Now there is the left lung, at least it's okay. There is now hyperinflation as compensatory hyperinflation. That's the reason why you see this it's too big and too dark compared to the left one. Okay, muzabyisomera nta kibazo. Icy'ingenzi, I just wanted to show you how we describe an image. So dufite iminota turacyafite 30 minutes sibyo turabyaza umusaruro ndabizi. Now it was we have just finished to discuss about I forgot to tell you something. It was I have talked, you have discussed the technique, how we approach the X-ray now, chest X-ray, in terms of three things, 3 steps: identification, technical qualities, and interpretation and analysis. See you?
Yes.
But I promised you that I will tell you the easiest way to look at the X-ray. So before I go to different diseases and how they look like on X-ray, let me come back and on this one. Normally, what we do, not me as me alone, even others in different hospitals, we look at chest radiograph through 4 parts. Number 1, after checking the identification and the technical qualities, okay. Okay, can you hear me?
Yes.
Hello. After checking those 2, now we read the X-ray. I mean, the analysis is done into 4 parts. The number 1, first of all, we have to know that we start by the center going to the periphery. By the center is about the mediastinum. And when we talk about mediastinum, you should understand from up there to down. Remember, you have to remember the anatomy of the mediastinum. Okay? The anatomy of the mediastinum. Because by looking at this image of the mediastinum, including the heart, sincerely speaking, there are some structures you don't see. And when you are analyzing this part of the mediastinum, you should think of them so that when there is any abnormality, any opacity and distortion of anatomical distortion, you immediately know what it is. Okay? Hello?
Yes.
Think about the trachea, think about the size of the mediastinum, think about the esophagus, think about the heart, all the structures in the mediastinum should be thought about. That's one. And by looking at this, you follow those 4 S's. Who remembers them? 4 S?
Size, shape, shadow.
And shadow.
The shadow as opacity. Okay? After that, switch off your mic. After that, you go, after the mediastinum at the center, you go to the lungs. From mediastinum to the lungs, you cannot pass, there is a door or a window. A window is not a step, but you should check them, that window. It is about hilum. You don't jump from the mediastinum to the lungs without checking the hilum. The hilum, we check the shape, the size, and everything as I told you. But immediately you go to the lungs. When you go to the lungs now, remember the zones, upper zone, middle zone, the lower zone, and check them very well. By looking at the vessels, how they are, orientation, is there any opacity? And you finish to check the lung by just checking the costophrenic angle. The pleura, I mean. The pleura is very important because in this part of the lung, it's where you can talk about the pro-effusion or not, any pro-thickening or not, because we consider the pleura as the cover of the lungs. Okay? That's the second part. Mediastinum, lungs, and you go to the bones now. Bones, you check each bone, one by one, including the spine, including the clavicles, including the scapula, including your ribs, And after the third, like bone, you got soft tissues. Everything that is soft tissue in the chest, please look at it. Starting by the neck, is there any neck mass, any neck lymphadenopathy? Is there any axillary mass? The chest wall, is it okay? No abnormality? And it is where now we check the diaphragm. Okay? The diaphragm, is it okay? The orientation, the smoothness, the site, and even here you can even think of abdominal organs, because like the liver, sometimes you can diagnose any liver lesion from there. It's where now you after that, those 4 things, you are done. So you see that it is easier than in the previous method, because here it's about 4 things: mediastinum, lungs, bones, and soft tissues. It is easier. You can make it very fast. Can make it very fast, okay? Because for me, I cannot take like more than I cannot use 1 minute for chest X interpretation. Because looking at the mediastinum to see if it is normal in size, shape, site, and shadow, I go immediately, I check very fast the hilum, and they go to lungs, into zones, very fast, see if there is no pleural effusion. I go to bones, very fast, I check each bone, and I go to soft tissue, neck, chest wall, and abdomen, and diaphragm. It's very fast done. So which one are you going to choose to use?
The second one.
The second one. The second one is the easiest one. Okay?
Yeah, it'll be easy.
Ntabwo ari bitumva se bitoroshye. N'ubundi uramutse ukoresheje the first one, you will still see the same structures, but it is somehow childish. A, B, C, D. This one is for adults. 4 things: mediastinum, lungs, bones, and soft tissue, and you have seen the same structures. Okay, so that's what I wanted to tell you. So for the next
Excuse me. Excuse me.
Yes,
like on this second method, where do we check the trachea, like the trachea deviation? In which part that I have not seen?
Oh yeah, none se trachea umva nkubaze ikintu, ahubwo hano hari ikibazo gikomeye. En fait, radiology yigwa n'abantu. Listen, can I answer the question? Radiology is done by, like CLAC has to do radiology. It is done by people who know anatomy. The prerequisite is anatomy. If you are stating in anatomy, don't come to radiology. Trachea is in which part of those among those 4? Trachea is in which one? None se abajije iki none? Yambazaga iki niba atari banga?
Actually, we are still studying.
No, don't think I'm angry. No, I'm just I joke if the people who ask some questions that are bizarre. I didn't see his face. Even if we meet, I don't remember him, recognize him. Okay? So no problem, just joking. It's a good question because maybe he didn't understand my explanation, my previous explanations. Okay, any other question from the second method? Silak, is it better? The second method?
Yes, the second is better.
It's better, it's very fast, and you cannot miss anything. But the most important should be systematic. Start by the center, go to the lungs, by passing to the hilum, and go to the bones and soft tissue, and you are done very fast. But that's done as the analysis after checking the identification and the technical qualities first. Okay? Any other question?
Yes, I have.
Ask the question.
When you are looking for the mediastinal content,
Your internet is not good.
When you find that there is a trachea deviation
Yes.
due to aortic arc, is that abnormality or that is normal in adult?
We say that's normal.
Yeah, thank you.
We say that's normal, but that is a normal variant of the trachea position. Okay. Any other questions so that I continue? Can I continue in 20 minutes?
Yes, you can.
Okay. So here, the next part of my presentation, this is even the last one, though it looks a bit longer than the remaining time, but no problem. Wherever we reach at 5, we stop. Okay.
Okay.
It's about now the approach we know. The issue now is about what are you seeing? How can you recognize any opacity, different opacities in the chest? What do you see? That's how now the signs come in, different type of opacities come in, you know. That's what we are going to see. Basic chest interpretation, chest X-ray, looking at some of the more commonly accounted pathologies now. We will split this up into abnormalities involving the lungs first. We talk about the disease of the prospaces. We talk about the disease of the heart, the hilum, the hidden areas. Remember the hidden areas, 4 hidden areas. Do you remember them? Posterior to the clavicles, posterior to the heart shadow, hilum, and posterior to the diaphragm. And the disease process involving multiple areas now. Now it can involve the heart is involved, the lung are involved, prostate is involved, like heart failure. Heart failure can involve the heart self, cardiomegaly. It can involve the lungs, pulmonary edema. It can involve the pleural effusion. You know, it can go into interstitium by lines and interstitial edema. You know, now different parts here are involved by one pathology. Okay. So those are things we are going to see. Let us start by, when you're looking at the lungs, start by the lungs. When looking at the lungs, the first step is to decide whether any areas look more white or black than they should be. Remember, when it is more white, it is opacity, it's opaque. When it is more black, it is lucent, hyperlucent, radiolucent. Those are terms we use, okay? And it is important to try to decide what pattern or what patterns of shadowing are present, as there are a limited number of each different pattern as a list of differential diagnosis associated with. So from one alveolar opacity, you can still have many differentials. In essence, opacities can be airspace. That's what they mean. Tutakuwa airspace opacity. You can have interstitial opacity. Remember what is interstitium? And the shape of that area, like airspace, the shape of opacity will be differentiated from interstitial one, because interstitial one will be either linear or reticular or nodular. But airspace opacity will be, most of the cases will be patchy, irregular opacity, big, patchy. But interstitial will be linear or nodular or combined reticular nodular, you know. So the space itself will now guide the appearance of the opacity. The opacity can be also caused by collapsed lung, or the whole lung is collapsed. It's opaque, collapsed. There is no air bronchograms because it is opaque. There is no air entering it. Or a small part of it, or it can be even it can be either lung collapse or atelectasis, a segmental atelectasis, or lobar atelectasis. Atelectasis is the same as a collapse, but when it is smaller part of the lung, we usually call it atelectasis. When it's a big lung, part of the lung, we call it collapse, lung collapse. We can have focal mass or nodule Now think of interstitium when you can start talking about nodules. We can have some multiple nodules or one nodule of multiple nodules, or can have some opacities related to the plural or plural spaces, including the pluralplex, plaques, or fusion, like that. So those are things we are going to see. Space opacities, interstitial opacities, collapsed lung atelectasis, focal mass nodule or multiple nodules, and disease related to the plural or plural spaces. Okay, now we are talking about lungs. Those are lung diseases. So let us first. Any question?
No question.
So let us now start by airspace shadowing or consolidation. Airspace shadowing, normally, do you know why we always confuse airspace shadowing and consolidation? Consolidation, it is typically any collection, fluid collection in the lung, normally. Okay? Any fluid collection in the lung is called consolidation. Is it okay?
Yes.
And consolidation doesn't mean it doesn't mean pneumonia. They are different, because consolidation can be caused by different, can have different causes, like it can be pneumonia. Pneumonia is a consolidation. It can be post-traumatic lung contusion. It can be, any collection in the lung is consolidation, but all consolidation is not pneumonia. Okay? Don't use consolidation at any time. When you are not sure about the reason of the opacity, the mechanism, the pathophysiology behind, by combining the clinical history and the appearance of the opacity, it is better to call it consolidation, not pneumonia. Okay? These are equivalent terms, like airspace shadowing and a consolidation. They are equivalent terms, and it is used by fluid filling the small bronchi, bronchioles, and alveoli. The nature of this fluid cannot be determined on the radiograph. That's what I was talking about, but could be pus infection, could be water as in pulmonary, could be hemorrhage, for example, in some of the vasculitis, could be malignant cells in alveolar carcinoma, or proteinaceous fluid. Just any consolidation caused by a different mechanism. Correlation with the clinical settings is required to narrow the differential diagnosis. Okay, this is very important for clinical people, for clinicians. So the hallmark talked about it. The hallmark of consolidation are air bronchograms. Usually, the smaller bronchi, the bronchioles and the alveoli, are not seen as they are filled with air. So and their walls are too thin to be detected on plain radiographs. I have talked about this, by the way. I'm just repeating myself. When the airspace fills up, the alveoli fill fast with fluid, with the bronchi being relatively spared. Therefore, the bronchi, which are still air-filled, stand out against the alveoli, which are filled with pus, fluid, or hemorrhage, and this is called air bronchogram sign. Ibi bintu ntabwo byumvikana. Is it clear? Twabivuze cyane. Okay?
Birumvikana.
So this is an example of air bronchograms. But you are seeing that I can see the opacity here. I can see, by the way, it is not just this. I can see if opacity in the left lung, the whole left lung is opacified, but there are some air bronchogram within it, within the opacity, but also there is a very big mass here in the right lung. This can even be a solid mass because it's homogeneous, well defined, well marginated, and there are also some nodules. Can you see the nodules, small micronodules? They are not normal vessels. They are micronodules in the lung. diffuse. Huh? Can you see them?
Yes, it is clear.
So what I want to say, maybe here they wanted to say this opacity of air bronchograms, meaning consolidation, but there are other, I don't see, there are other opacities like this well-defined homogeneous opacity. There's some diffuse micronodules in the right lung. Due to the diffuse dense consolidation within the left lung, it is possible to see the main left bronchi. Yeah, main left bronchi, it's there. Dividing into smaller, more peripheral bronchi. I just wanted to talk about air bronchogram sign, but they ignored these other signs. Okay, I think this can be anything. This can be cancer, mediastinal lymphadenopathy, maybe it can be cancer, lung tumor, if met, it can be anything. But the reason for this is for air bronchograms. Okay, again. On the image here, we can see a very well marginated opacity. But when you're in the right upper lobe, this is horizontal fissure, and the right upper lobe. And if you look very well, you will see that there are some tubular structures that are air bronchograms. Can you see them within it? Those are air bronchograms, meaning this is a consolidation. Okay, but it is well marginated here because it is limited by the fissure. Otherwise, consolidation or alveolar collection, it's not well limited, apart from when it is limited by the fissure, or in the case of what you call round pneumonia, that is seen mostly in children. Round pneumonia, it's a round opacity, homogeneous, with no air bronchograms, very well marginated. That's round pneumonia, seen in children. But otherwise, the alveolar opacity, they are patchy, irregular, and they are not well marginated. You see, here it is a magnified of this one, trying to show the air in the bronchi, air bronchograms. Okay, the images show increased airspace shadowing in the right upper zone. Here, they should not use zone; they should use lobe, because we are very sure that this is horizontal fissure. They should not use, maybe they will change later, with the dark tubular air bronchograms once again clearly visible. In this case, it's possible to say that the consolidation is okay. The consolidation is upper lobe, as the consolidation is clearly limited by the horizontal fissure, which you will remember separated the upper lobe from the middle lobe. Okay, that's one. That's good. Okay. Is it okay?
Yes.
Here now, another image. What we see, I can see the good, technically not bad chest radiograph. Now it is a patchy opacity in the left lung, patchy opacity in the left middle and the lower zone. That is patchy. It is irregular, but it is alveolar, and it is silhouetting the left margin of the heart. The left margin of that is silhouetted, and it has air bronchograms. So I'm very sure that is alveolar opacity. It is a consolidation, in other words, unless they give me some clinical history so that I can talk about now pneumonia or something. They say there is chest pain and fever. If this opacity, I call it in my conclusion pneumonia. What I can tell, I'm very sure that this opacity is in the middle, it is in the lingular segment, because you remember lingular segment is the one that's in contact with the heart. That's the reason why you have silhouette sign positive. Okay, let me see what they have written. This an example shows patchy opacity. Yes, irregular opacity in the left mid and the lower zone, with a few air bronchogram visible, very few. The left heart border is no longer seen, and so using our knowledge of the silhouette sign, yes, we can be quite confident that the consolidation is affecting the lingular lobe. But it's called the lobe, it's not the lobe. It is lingular segment, as it is this lobe, this that about the left heart border. I will remove. I don't know the reason they have written. Don't trust anything you read in the internet. It is not a lingular lobe. There's nothing like lobe. It is segment. Okay. Let us go to this one. The image on the left side. Okay. The left side, you can see this is the diaphragm. This is the left diaphragm. We can see this very well defined homogeneous opacity. Parahyla, because this is the hilum, the right side, parahyla. This is the aortic arch. Don't call it a mass. In continuation of the descending aorta, the left hilum is normal here. Lung nodule, this is a nodule or mass. Lung nodules may have various different features. However, they will typically not observe the boundaries of the normal anatomical lung compartment. They are not limited by feature or something, such as the large right-sided nodule seen here. This nodule can be a mass, lung mass, or can even be higher lymphadenopathy. But also, if you look very well, you compare the zones, I can see something else like here. Can you see the small nodule here again? Can you?
Yes.
Yeah, if I see this now, I fear that this may be malignant process, because I see these two things, this mass and another nodule there peripherally. I fear of malignant process. Cosophrenic angles are sharp. The rest of the lungs are clear. The mediastinum is okay. The heart size is normal. So nothing else but these two nodules or masses. Okay. When you look at this one, remember I told you something. You can see that patchy opacity in the right lung, patchy opacity with air bronchograms, the dark one. Air bronchograms, sincerely speaking, if I look at this without telling me the clinical history, I would call it pneumonia or any pneumonia, alveolar consolidation. But I told you that bronchoalveolar carcinoma can look like pneumonia or consolidation. This was the case of bronchoalveolar carcinoma after biopsy. But let me tell you, you can't tell without being given some clinical history, chronic weight, loss of weight, chronic cough, no fever, even some lab results in favor of cancer. If they don't tell you those give you those clinical history, those clinical findings, you cannot think of bronchoalveolar carcinoma. But put in your mind that bronchoalveolar carcinoma can look like alveolar consolidation. Okay? So, ladies and gentlemen,
Lecture
I
on
would
the
like to not continue by here because it is now 4 to 6 to 5 to 5. I cannot start another part of the opacities, interstitial shadowing. No, I start by another day or maybe on Monday. But ask question about airspace opacities there.
lecture. I have a question.
Ask.
On the next image.
I can hear you. Hey, which next image? The next one? This one?
Yes. You see that we have. You said that we have a air bronchogram, but I have failed to differentiate it with the line we have seen, and even the vascular marking. They are all same.
Okay, you are not wrong. You are not wrong because it is a mixture of alveolar opacities like here and some area of linear opacities like that. Yeah, it is a mixture of both, but the predominant one is alveolar opacity. Alveolar opacity with air bronchograms, but there are some mixture of linear or lenticular opacities. Okay. Any other question? Any other query?
Can you share us the note?
Sorry? Sorry, your internet, please.
I wish, if possible, you can send us the slides.
I will. From the maybe I send slides of what we have seen already. All right.
Yes, right. If it's possible, you can send the whole slide so that we can start to make a plan of how we are going to revise.
Even what we didn't see, we have not yet seen.
Okay.
Yeah, if no effect.
Huh? No effect.
If
If you
possible.
even read through them, and when we meet now, next time to read it.
Yes, for
Okay.
sure.
I will send the
Yes.
CP of Paco and the Huye. No problem. Send me your emails. Okay.
Actually, we have a class email. I think it's one.
I can even send. Just send an email where I can send the slides.
Yes.
Okay. So we call it a day.
Yes. Yes. Thank you, lecturer.
No, so you will talk and tell me when you can have another day, because we need another day. We need another day, another full day next week.
Lecturer, what will be then the time of exam?
What will it be?
The time of exam, if next week we can continue.
I don't tell others to switch off the mic. So that we can hear you.
Lecturer, I'm asking you when it will be the time of exam because yeah, we continue on the next week and we
Okay,
have.
listen. Remember that you have even the Dr. Carissa Ruiz should teach you next week. By the way, write her number, phone number, so that you can contact her. Hmm?
Yes, and also we have a dermatology yet.
Listen to me. Listen to me. Ntumbwire ibya dermatology mwanze ko mwatumye